The guidelines for the management of heart failure were updated in 2016. One of their new recommendations said that for patients who are currently tolerating an ACE or an ARB, that they could be switched to this new medication called Entresto, and that it would provide further mortality benefit. So let's look through the Paradigm HF trial and see how they came up with this recommendation. So first off, what is Entresto? It is a combination product of valsartan and sacubitril. And it's not just your standard combination, it's actually a fused molecule or a co-crystallized molecule. And so they give it a new term, they call it an ARNI, which is how it's represented in the guidelines, which is an angiotensin receptor neprilysin inhibitor. So we're familiar with valsartan, which is going to block the RAS system, but sacubitril, which is the neprilysin inhibitor, blocks that enzyme, neprilysin, which is responsible for the breakdown of BMP, bradykinin, amyloid beta peptides, and other vasoactive peptides. So when you inhibit that breakdown, you allow the valsartan to work more effectively. So I included the reference for the Paradigm HF trial at the top here. Make sure, as always, go look this up and actually read through the trial on your own. I have the PubMed ID on there for you as well. But just as a very, very brief summary, the trial was a multi-center, randomized, comparative trial. There was over 8,000 people in the trial, and it looked at Entresto 200 milligrams or valsartan sacubitril twice daily versus enalapril 10 milligrams twice daily. And their primary outcome was a composite of cardiovascular mortality or hospitalization due to heart failure. Some of the inclusion-exclusion criteria. So for the inclusion criteria, patients had to have HFrEF with an ejection fraction less than 35%. They had to be on an ACE or an ARB for at least 4 weeks prior to the study. They also had to be on a beta blocker for at least 4 weeks. Some of the exclusion was a systolic blood pressure less than 100, an estimated GFR of less than 30, and patients could not be enrolled in the study if they ever had a history of angioedema. So here's some of the results that were reported, and there's others as well, but these are the ones I want to focus on. So for the composite, you see a number needed to treat of 21. So for every 21 patients that we treat with Entresto, as opposed to enalapril, we're going to stop one extra case of cardiovascular death or hospitalization due to heart failure. And then when we look at the components by themselves, we still get pretty significant differences clinically speaking. So cardiovascular mortality number needed to treat was 31, and hospitalization number needed to treat was 36. Adverse effects were pretty similar. The ones that stood out, so symptomatic hypotension was more prevalent in the Entresto group. So in this case, number needed to harm was 21. So patients that are on Entresto definitely need to be monitoring their blood pressure on a daily basis. And there were some patients who even got to a systolic blood pressure of less than 90. And in this case, number needed to harm was 77. Potassium was also monitored, and patients who reached a level of 6 or more were included in this here. And it wasn't a significant difference, but it was trending to be worse in the enalapril group. So that's one extra benefit for Entresto. If you have a patient who is starting Entresto and they're currently taking an ACE inhibitor, make sure that they stop the ACE for at least 36 hours prior to starting the Entresto. So the sacubitril component of Entresto increases someone's risk for angioedema. And so when you take that along with an ACE, that risk goes up even more. So I've actually seen this happen firsthand where a patient was given samples of Entresto, wasn't aware that he was supposed to stop his ACE inhibitor, took them together and ended up in the hospital with angioedema. And technically speaking, because he has a history now of angioedema, he's no longer a candidate for Entresto. And so he may have missed out on an opportunity for a good medication because of a failure to consult. So something to keep in mind, always make sure we're talking to people about this 36-hour washout between the ACE and the start of Entresto. Typical starting doses, 100 milligrams twice a day, titrating 2 to 4 weeks or so in increments, and with the goal dose being 200 milligrams twice a day. BMP should no longer be monitored. So BMP is broken down by naprolysin, so if we inhibit that enzyme, obviously BMP is going to go up. So that's no longer going to give us an accurate clinical picture. If you want something similar, just draw a pro-BMP instead, and that won't be affected. Some long-term concerns that we have, one is age-related macular degeneration, and the other is Alzheimer's disease. So the amyloid beta peptides that are normally broken down by naprolysin, once that's inhibited, that breakdown, they in theory could start accumulating and form the amyloid plaques that are a concern with Alzheimer's. So this is something that they're monitoring very closely, and only time will tell to see if it's an actual concern or not. As far as macular degeneration, if a patient comes and is very concerned about this, or they have a family history of macular degeneration, you could always recommend one of the different brands of eye vitamins that contain the AREDS 2 formula, which is the lutein and zeaxanthin. In the AREDS 2 trial, we know that there was a little bit of benefit when taking that combination in the reduction of the development of macular degeneration. I don't have any evidence whatsoever to back that up as far as whether or not that would be significant for patients taking Entresto and whether or not that would help, but it probably won't hurt, so it may be an option to try in certain patients, just to keep that in mind. Let me know if you have any questions, concerns. I'd love to hear your comments and what you think about the trial. Feel free to post them. Thanks for watching.